So, great speech. Now we move to the median nerve, just to identify some sites of nerve entrapment, not just the carpal tunnel, and then a large part of my talk will be about this last area, just to discuss some important things to remember when we go there to check the median nerve. So you know, in the arm, the median nerve descends the medial aspect, passing in a division of the medial intermuscular septum, together with the brachial artery and some brachial veins and the basilic vein. Remember that the brachial artery represents the best landmark to identify the median nerve. The median nerve passes any time close to the brachial artery. It may then cross over the artery or just deep to it, changing its respective relationship just in the mid-proximal arm. But anyway, in general, there is no problems for ultrasound to identify the median nerve and to follow the fascicles from proximal to distal. Regarding site of compression in the arm, we remember the supracondylar process. That is a beak-shaped process located more or less here on the medial aspect of the humerus, just as 7 centimeter proximal to the medial epicondyle. And this process is a re-expression, genetic re-expression of something that is already present in some animals, especially lemurs or cats. If you refer to these animals, you know that the humerus of this is an image of a humerus of a cat. You see that there is a tunnel here, and the cranial part, the ossified part here, is related to something like a supracondylar process. And these kind of animals have an accessory muscle on the medial aspect of the arm. So we have the triceps posteriorly, the biceps anteriorly, but in cats, for instance, we have the latissimus condyloideus, and the latissimus condyloideus is an intermediate muscle between the triceps and the biceps, going to insert just here, just at the level of the ring you see in this image, and this is part of it, and probably re-expressed. Some genes may be re-expressed in humans, as you know. This is very fascinating on the genetic point of view, and the point is that this beak-shaped process may create problems to the median nerve, not to the ulnar. The ulnar, it passes more posteriorly, and in some instances this beak is completed by a ligament, as you can see here, just to reproduce what was visible in the humerus of cats, and this ligament is named the Strader's ligament, and this becomes an osteofibrous tunnel, and the median nerve and the brachial artery may pass across the tunnel here, so they may be impinged against the ligament or against the bony process. This is an example, and you see the beak process here, and these are the nerve and the vessels close together in close relationship to the process. To me, this is a very rare occurrence, but probably we miss many of these cases because we don't place the probe there. That's the point. And when we place the probe there, we are very fast. And believe me, this is very thin. You can miss. You have to scan slowly, not very fast here. If not, you miss. I remember one case. I was really busy, and I passed the probe so quickly over this area, and just at the end of the examination, I realized that there was the supracondylar process. So this is the position of the ulnar nerve. This is the brachial artery, the median nerve. In some instances, the artery may pass outside, as you can see here, and the median nerve crosses the space here. This is another example. You see the finger-like process associated with the humerus. And you know that if this is the finger-like process, this is the Strader ligament, and this is the pronator teres going to arise from the ligament, as you can see here. So the pronator teres in these cases arises more cranially. This area is incredible. The area close to the medial epicondyle, it contains a lot of variants, a lot of accessory muscles. Javier mentioned medial epitrochlearis, and but there are also the chondroepitrochlearis, that is a muscle passing here and going to insert into the medial epicondyle. There are a lot of conditions that may the anconeus epitrochlearis, sorry, that may create some problems for the nerves passing in this area. So this is the only case in my life I have with some compression of the median nerve. The median nerve was compressed, passing across the tunnel. This is the finger-like process. This is the artery located outside, and this is the median nerve. Very, very thick, as you can see here. So going down, you know, the median nerve enter in an area that may leave you some doubts, some perplexity. You know, when you place the probe over the wavy course, the wavy appearance of the distal humeral epiphysis, and this is a very important landmark, sonographic landmark, to identify the different structure in the anterior elbow. You see, you have a big muscle in the center, and this is the brachialis. Then you go laterally, and you have the brachioradialis and the extensor carpi radialis longus. In between the brachialis and this muscle, we have the radial nerve. But if you go to check medially, you have another muscle, and in between the medial side of the brachialis and the pronator teres, we have the median nerve. So this is the position of the biceps, the artery, and the median nerve is located medial to the artery. This is a potential site of nerve compression. You know, the pronator area, the area where the median nerve passes underneath the lacertus fibrosus when it passes deep to the pronator teres. So remember that the pronator teres is characterized by two bellies, and more distally, another critical point is when the median nerve crosses the space underneath the arcade of the flexor digitorum superficialis. All of these parts are critical for the median nerve, and there is much literature describing possible compression of the nerve in this area. But to me, is so not easy to find cases in which you have a definite compression of the nerve. I saw a lot of pathological changes, these immune neuropathies, a lot of things, but I'm not really convinced that the median nerve may be entrapped in this area. So there is, at least the ultrasound is not so sensitive to demonstrate any change there. You can see some abnormal relationship of the nerve with the artery. You can see, but at the end you don't have any specific finding to conclude that the nerve may be compressed in that area. In some instances, I think MRI is more sensitive because it can see a hyperintense appearance of the nerve related to the accumulation of water in the vesicles, but this cannot be seen on ultrasound. But to be honest, I have a list of incredible traumatic injuries, a list of these immune neuropathies, a list of any kind of pathology, but I'm not really, I don't have any convincing case in which I see the median nerve compressed in this area. This is also critical because the nerve sends here, gives off a branch, a motor branch, the anterior interosseous nerve, and the anterior interosseous nerve detaches from the median nerve, and then it passes in a cleavage plane between the flexor pollicis longus and the most radial side of the flexor digitorum profundus, just to reach the interosseous membrane. This nerve may be compressed in this area, may be compressed in between the two muscles I described before, and here is really a nightmare, no, because we have a lot of potential causes for nerve compression, including fibrous bands. Fibrous bands. Look at this picture. Is really very complex, you know, and you see a lot of accessory structures potentially compressed in small vessels. The point is that, again, ultrasound is not really sensitive to demonstrate compression of the anterior, to evaluate the nerve directly, because the nerve is small, too small. No, so if there is a band, the band is not visible. A fibrous band is not visible, and the nerve is too small to perceive a change, an abrupt, a sudden change in the orientation of the nerve trunk. So the diagnosis is essentially based on detection of abnormal of denervation signs in the innervated muscles. And the innervated muscles are the pronator quadratus, are the radial aspect of the flexor digitorum profundus, and the flexor pollicis longus. So you place the probe over this muscle and you see some atrophic changes. No, you ask the patient the usual tests. No, to perform a ring, you understand that there is a weakness in the flexion of the distal interphalangeal joint of the index and the interphalangeal joint of the thumb, and that's it. No, then doubts may remain, because when you scan the nerve in this area, you say, oh yeah, this is there is involvement of the flexor digitorum profundus, there is involvement of the usual muscle supplied by the anterior interosseous nerve, and then there is involvement, I don't know, of the flexor carpi radialis. No? Why? No, probably because the just proximal to the level of the anterior interosseous, we have also some small branches to this muscle, and possibly the compression may be not really proper of the anterior interosseous, but it may be a bit more cranial, affecting the median nerve in a variable way. So this is a distal image of the nerve reaching the area of the pronator quadratus after removal of the flexor. You see the nerve and the small artery close to the interosseous membrane. It's a bit frustrating, I feel. No. Then remember that, as Jordi said, some congresses. I don't know, in Barcelona, in one of the congresses, this is absolutely true. This nerve is often involved by Parsonage-Turner syndrome. So there are some conditions in which the nerve is involved, not just a result of compression. So it's really difficult. So you have to refer to muscles. Remember the Ganser. The Ganser is an accessory slip of the flexor pollicis longus muscle. You know, the flexor pollicis longus is located here, very close proximity to the radius, no? And then, if in some instances, you can see, yesterday we have a demonstration in the room upstairs, we have a small bundle here that is an accessory, is the Ganser muscle, is part of the flexor pollicis longus, and if you ask the patient to flex and extend the interphalangeal joint of the thumb, you can see this muscle moving. And this muscle, when it is not small but relatively big, is believed to predispose the nerve to local entrapment. No? So how to identify the Ganser? You see a small muscle just deep to the median nerve. This is the median nerve. This is the Ganser. No, it's isolated here. Where is the flexor pollicis longus? The flexor pollicis longus is more radial, is close to the radius here. No, this is a video clip, and you see the flexor pollicis longus here, and this is a big ganser contracting here. You see the median nerve, and this is the area of the anterior interosseous nerve. So there is some literature about the potential compression of this muscle on the nerve, but of course you can report that a muscle is present, that the patient has atrophic changes in the muscle supplied by the anterior interosseous, nothing more. You cannot imagine to demonstrate a change in size of the anterior interosseous. This is the typical appearance of of what happens in these cases. This is the healthy side. You see the flexor digitorum superficialis, flexor digitorum profundus, the flexor pollicis longus. These muscles are more or less the same on the affected side, with the exception of the flexor digitorum profundus that has some atrophic changes. Of course, in some instances, the syndrome may affect one of the three muscles involved. You can also have a partial anterior interosseous syndrome. So it's a very difficult point. And you have just to be very accurate to describe what you see, and then nothing more. Moving down to the carpal tunnel, you know that the median nerve descends the forearm, and then it enters the tunnel passing superficial to the flexor tendons. No, this is a representation of the area of the tunnel, and the tunnel is delimited by a retinaculum, the flexor retinaculum. When you go to scan the carpal tunnel, remember to consider bones as landmarks. It's very important. And the carpal tunnel in itself has two levels, proximal and distal, in which the scaphoid, the tubercle of the scaphoid, and the pisiform represent the best landmark to image the tunnel proximally. And the tubercle of the trapezium and the hook of the hamate represent the distal carpal tunnel. So anytime you place the probe in this area, you have to see on one side of the image the scaphoid, on the other side the pisiform, on one side of the image the trapezium, on the other side the hook of the hamate. If not, the probe is not really oriented in the short axis of the nerve, and you could also overestimate the nerve area. But remember that even that the examination shouldn't be limited at the level of these bones. You have to start much more proximally. Then you descend with the probe towards the tunnel. You place the probe aligned to the scaphoid and the pisiform to the distal landmarks, and then you have to continue in the palm to be accurate. So this is the shape of the scaphoid and the pisiform. They are round. So very easy to identify them. The scaphoid is easier because it has also a tendon like a cap, no? And the tendon is the flexor carpi radialis. And on the other side, the trapezium is relatively flat, as you know, and the hook is the most medial, very pointed. And on the other side, you can see the origin of the hypotenar muscle from the pisohamate ligament. So this is relatively easy. What to see in a patient with the carpal tunnel syndrome? Swelling of the nerve proximal to the compression point, and this is the most important sign. And this sign can be, in general, is appreciated not at the level of the proximal tunnel or at the level of the pisiform, as reported in many papers. But in general, it's located at the proximal boundary of the retinaculum. This is a sign of impingement between the nerve and the proximal boundary. The flattening of the nerve within the distal tunnel, within the tunnel, is less important as a sign. It may increase your confidence in the diagnosis, but basically the enlargement of the nerve is the main finding you have to check. And to do that, to me, pattern recognition is enough. So you start proximally, you drive the probe down very, very not so slowly, and you have an idea of the area of the median nerve, and what you see is in a carpal tunnel syndrome is that the nerve increases in size, then it flattens abruptly when it enters the tunnel. This is enough to make the diagnosis. Remember that ultrasound, yes, may help, but at the end is carpal tunnel syndrome is a clinical diagnosis. It's important that these signs are not, you have not to look at just where you expect to see the thickening of the nerve, so at the level of the entrance of the tunnel, just to check the what happens at the level of the proximal boundary of the retinaculum. In some instances, the problem is distal. And so if you remain here with the probe, and this is the one of the mistakes for beginners, you can miss a more distal compression. In some instances, you can have a completely normal nerve proximally and a very big nerve distally. And of course, when you have to measure, in these cases, when you have to calculate the cross-sectional area, you have to calculate at the point of maximal compression. It has no sense to measure the nerve proximally here. So to me, this is not really recognized by everyone in the scientific community. But to me, the best, you have to measure the cross-sectional area at the point where there is the maximum enlargement of the nerve, because this is the point of maximum severity. You shouldn't refer to a landmark. If not, you can underestimate the condition. This is a long axis image showing that the nerve is fairly normal proximally, and then it's very big distally. This is the nerve, relatively normal proximally, then very big as it exits the tunnel and as it enters the palm. In this case, the compression is probably located in the distal part. There is also a nice finding here. You see a giant motor branch of the nerve detaching here to reach the muscle of the thenar eminence. Considering the nerve cross-sectional area, you know better than me. So at the end is easy to measure. You are free to select the best way. You have to apply the ellipse formula, visible here, to calculate the area. Again, where is the level of nerve measurement? Where the nerve is maximally enlarged. Which is the threshold value is more tricky, as you know. There are millions of papers about that, but the point is that there are in the carpal tunnel there are a lot of potential confounding factors, and this is the reason for which we cannot select a specific measurement as a cutoff between normal and pathologic. In general, we use 10 millimeters square. But there are a lot of variabilities in terms of gender, weight, body mass index, race. And this was the reason for which in the same year, 2008, Andrea and Lisa published 2 papers to refer the area of the median nerve at the point of maximal enlargement with the area of the nerve calculated outside the point of compression. Andrea decided to calculate a difference. Lisa selected another way to calculate a ratio. Anyway, the nerve was compared with itself, just to improve the accuracy in the diagnosis. And as you see here, they were very optimistic about the possibility to be highly sensitive, highly specific, and so highly accurate in the diagnosis of carpal tunnel syndrome. The measurements were also applied to the to patients in which there is a bifid median nerve. This is a very common occurrence in the carpal tunnel syndrome, suggesting to calculate the area of the 2 components of the nerve at the point of maximal enlargement. Then the area of the 2 components of the nerve at the level of the proximal pronator quadratus, and then you calculate the difference, and if it's 4 millimeters square or more, it means that the nerve is compressed. I reported these measurements, but I don't love to spend much time with this. If you drive the probe from proximal to distal, in many cases the diagnosis is so evident you can perceive that the nerve is compressed. This is a bifid. It's very thickened proximally and then flattened within the tunnel. Ultrasound, don't forget to check some important branches of the median nerve close to the carpal tunnel. One is the palmar cutaneous. You know that the palmar cutaneous detaches very proximally in the median nerve, so the distal radius, and then it pierces the antebrachial fascia or the proximal part of the retinaculum to move into the subcutaneous tissue and supply this area. This nerve branch is very well known by orthopedic surgeons, you know, especially because it may be damaged during carpal tunnel release if the surgeon selects a too radial surgical access, because this is radial relative to the position of the median nerve. So in these cases, the patient has a complete improvement in the symptoms, in the finger symptoms, but there is pain or some sensory disturbances at the level of the proximal part of the palm. The second branch that is interesting, and ultrasound can demonstrate it, is the recurrent motor branch. It's, you know, after the median nerve exits the tunnel, it divides into different branches. No, one is a common trunk here to give origin to the radial collateral nerve of the index, to the two collateral nerve of the thumb, and at the base of this trunk, visible here, we have a branch changing its direction and going back to supply the muscle of the thenar eminence. This branch is named the recurrent motor branch, also the $1 million nerve, because if resected, the lawyer can ask you more or less $1 million. And ultrasound can see it very well. Just some example of the compression neuropathy of the palmar cutaneous branch. So you know the palmar cutaneous branch may be damaged after surgery, but it may be also compressed. Where is the site of compression? When the branch pierces the fascia, of course. No. So this is an example in which you have a patient with a carpal tunnel syndrome. You recognize here the median nerve. We go towards the carpal tunnel, and you see the swelling of the branch just proximal to pierce the fascia. This is the nerve swelling. This is the fascia. This is the point where the branch enters the subcutaneous. It was compressed there, and ultrasound is perfect to demonstrate these points. This is an example of a problem affecting the palmar cutaneous branch after carpal tunnel release. You see the site of the release is radial sided. You see the median nerve again. I activate the video. This is the nerve, and you see the nerve embedded in the scar. This is the surgical scar, and you see that it was resected within here. At the level of the scar. So ultrasound can demonstrate the problem. Remember that there are some anatomical variants for which the palmar cutaneous may arise not from the radial side but from the ulnar side of the nerve, no? And then it pierces the retinaculum, passing over the nerve to reach the flexor carpi radialis. This is, I think, in 2% of patients. So when you place the probe over the carpal tunnel, you see a dot crossing over the retinaculum. This I think may be a useful information for the surgeon. If you go there and you cut the palmar cutaneous branch, because the palmar cutaneous branch passes just superficial to the median nerve in this area. And this is an example of a thickened recurrent motor branch, entrapped just distally when the nerve exits the tunnel. There is a vertical part and then an horizontal part of this branch. In general, the vertical part is thickened as a result of impingement against the distal edge of the retinaculum, and you can have this kind of pictures with denervation signs in the muscle. This can be also seen on ultrasound. So moving to the causes producing the carpal tunnel, remember flexor tenosynovitis. Yesterday we also described something about that. Remember that in normal cases the flexor tendons are close with each other in the carpal tunnel, are packed together. You don't see the hypoechoic eleo in general, because the tendons are very closely opposed in the tunnel. You see a homogeneous hyperechogenic pattern. Of course, you can see also anisotropy at the level of the flexor tendons, and this may help you to exclude any tenosynovitis. So remember to place the probe anytime perpendicular to the tendon. You have to tilt the probe to avoid any hypoechoic pattern there. If not, you can confuse the picture, and you can believe that there is a tenosynovitis and there is not. Another important maneuver you can perform just to be sure that synovitis is there or not is to invite the patient to flex and extend the fingers. And so if you see this kind of images, you understand that this is not related to any muscle. The hypoechoic image you see here is some fluid at the level of the sheath. So dynamic scanning may help to be sure that tenosynovitis is present. Then there are overt cases, but my suggestion is anytime you of course spend the time to check the flexor tendons when you scan the median nerve for carpal tunnel syndrome, but be accurate and go down, check the floor, because in some instances you can have pathology at the level of the floor. If you start with the too magnified setting just to see the fascicles of the median nerve so big in the screen, the image is fantastic, but then you can miss a ganglion located deeply, or in this case the distension of the ventral recesses of the wrist joints, and this may elevate the tendons, and it may be the cause for compression of the median nerve against the retinaculum. So check this area systematically. And where to start, where to end. Go proximally, because in cases of tenosynovitis in general, the sheath is distended much more proximally, and even is more evident distally than within the tunnel. Just if you have any doubt, go there. And be careful, because in some instances there are some mimickers of tenosynovitis. One of the most common is represented by the lumbrical muscles. And lumbrical muscles, we discussed these muscles yesterday, are attached to the flexor digitorum profundus tendons, and they will insert more distally in the extensor hood. But in some instances, they have a very proximal origin within the carpal tunnel, and so they may contribute to a carpal tunnel syndrome, but what is important to remember for ultrasound is that they can mimic flexor tenosynovitis. Look at this image. You see the median nerve so nicely. You see the flexor tendons, and what is that? Tenosynovitis. You go more distally, and if you go distally, you realize that this was just the proximal end of the lumbrical muscles. So be careful, because this may be systematic anytime. Go distally and you understand everything. Then it's also it's important to check the floor of the tunnel, because in some you can also have not only joint problems but also bony problems. The dizzy condition. Not uncommonly, when you have a dizzy, you can see images like this one, in which there is a prominence of the ventral prominence of the lunate as a result of rotation of bone, and then you can see the displacement of flexor tendons. Look at the position of these tendons is absolutely abnormal, and then you see the swollen median nerve compressed against the retinaculum by the fact that the lunate is displaced ventrally. And finally, we have a list of muscles to, don't forget them, because we have a lot of variants in the hand. These are just the most common anomalies. One may affect the palmaris longus. The palmaris is a very small muscle characterized by a very, very long tendon descending the forearm, and then going to insert more distally on the retinaculum. Remember that today is the cat day, I don't have cat, but anyway, the main function of this muscle was to expose the clothes in cats and other mammals. So we don't expose clothes, no, of course, and so it's rudimentary in you, at least perhaps some ladies, I don't know, but anyway. So it's a rudimentary muscle. Remember that the palmaris longus may be fleshy until the end, so it may occupy space until the end, so close to the carpal tunnel, and this may disturb the function of the median nerve. But the most interesting condition is when you have a reversed palmaris. So that the tendon is located proximally and the muscle is located distally. Don't ask me why. I don't know. But anyway, this was the case of a patient who had this kind of lump, no? And she developed. She moved from one piso to another piso, and so she had much work to do to transport material and so on. And after that, she had the onset of carpal tunnel syndrome. Looking at the image located here on the ventral aspect of the wrist, we realized that it was related to a reversed palmaris. So placing the probe here proximally, just a tendon. Where is the palmaris? I don't see the palmaris. Then more distally, a lot of muscle, more layers than expected. So you see the pronator quadratus, flexor digitorum profundus, flexor digitorum superficialis, and what is that? Is the palmaris longus. And after inviting the patient to clench her fist, to compress, to activate the flexors, this what we could see. So the contraction of the palmaris, and you can see here the compressed median nerve by the action of the muscle. So remember this accessory muscle. This is another one that is very interesting, is the palmaris profundus. Palmaris profundus is not a variant of the palmaris longus. Is an accessory belly of the flexor digitorum superficialis. And if you look at these MR images, you can identify an additional tendon here and here. This is the tendon that passes superficial to the median nerve. It goes to attach into the retinaculum, but when you have a flexion of the flexor digitorum superficialis, this is what happens. This was a case of a carpal tunnel syndrome. You see the swollen median nerve. This is the tendon. During contraction, you see the tendon going to clash again the median nerve, going to compress. You see the saddle-shaped deformity of the median nerve induced by the tendon. You know that this muscle is also named the musculus concomitans nervi mediani, and in some instances it pierces the median nerve. I remember one case in my life, but I don't have the images. I saw a tendon passing inside the median nerve, and for me was very strange, but was at the end of a long day. I didn't print images, no, because I believe it to be drinking, no. But then I discovered the problem. In some instances, this tendon may be included in the median nerve. So you see the fascicles, and you see a small tendon parallel to the fascicles crossing the area. This is another very common variant, is the gastric flexor digitorum superficialis of the index. Digastric because it's located here. Is an accessory belly. It started within the carpal tunnel, and then it expanded in the palm. Here you see the example of this accessory muscle. It may form a lump over the palmar aspect of the hand, and as usual, when there is a lump, the orthopedic surgeon take a needle and no. There is no fluid. Why? No. Because there is a muscle. So you see two the bifid median nerve in the middle. You see the muscle starting here and then expanding more and more distally over the tendon of the index. This is another example in this case, orthopedic surgeon didn't insert a needle, but resected part of the muscle, leaving the rest of the muscle in the hand. And you see that in this case, the tendon of the index, the tendon of the flexor digitorum superficialis, was included in the muscle, just in the middle of the muscle. This is another very common variant. And my last slide. Thank you very much.